¿Necesitamos consent forms or no?
Hello.
Sí.
So, time to start. Thank you all for coming. Good morning. Welcome to this side event on decriminalization, separating facts and fiction. My name is Michel Kazachkin. I'm with the Global Commission on Drug Policy. And I'm very pleased to moderate this session, which takes place, I must say, at times of an unprecedented information crisis in global health and across society. So thank you to the organizers, that is Dejusticia, the Drug Policy Alliance and Release, and also the co-sponsors, Amnesty International, the Canadian Drug Policy Coalition, Decentir, the International Center on Human Rights and Drug Policy, the International Drug Policy Consortium, the International Network of People Who Use Drugs, and the Latin American Network of People Who Use Drugs. As you all know, in November 2020, 50% of the voters in Oregon approved the drug decriminalization and addiction treatment initiative, so-called Initiative Measure 110, becoming the first state to decriminalize possession of small amounts of any type of illicit drugs. And Measure 110 also funneled large amounts of funding toward treatment of dependence, harm reduction, prevention of overdose, housing, peer support. However, in 2024, last year, state lawmakers rolled back provisions of Measure 110 on the basis that it had led to an increase in crime, overdose, homelessness, and increased drug use. So since September 1st, 2024, possession of small amounts of illicit substances is once again considered a crime. The evidence, however, and we'll hear from Stasia, the evidence, however, is that the law was achieving its goals in decreasing the number of arrests and increasing access to care. And evidence has been accumulating, as you would all know, over the years, for decades now, on the ineffectiveness of and the harms of criminalizing drug possession and use. And that evidence is also discussed in our latest report of the Global Commission, Beyond Punishment from Criminal Justice Response to Drug Policy Reform, which is just out of the press on the site of the Global Commission, and which also offers a roadmap for decriminalization, harm reduction, legal regulation at the center of public health and human rights-based drug policies. So today's discussion will be about how misinformation spreads and about political reconstruction of evidence and how that reconstruction actually impacts on public opinion and on decision making. And it will take at a time when we're seeing a backlash on drug policy reform in many places in the world, including the US, including Canada. So, and I can't refrain from saying that these issues we should take in a broader context, also reflecting on the broader information crisis or information war that is going on in global health and across societies, including thinking particularly of the appalling decisions of the US administration to limit and block some crucial information on public health and public health emergencies. So we have an excellent panel to discuss these matters. I will introduce the speakers as they come to stage somehow. I will respect speakers to limit their speeches, interventions to 7-8 minutes, so we have a bit time for discussion. And thank you all. I don't know whether there are no more seats available. Sorry, you'll have to stand. Welcome again, and let's start. And our first speaker, I'm very pleased to say, is Stasia Naidoo. policy advocacy at the Drug Policy Alliance in the US, an organization that is familiar with many of you, working to address the harms of drug use and drug criminalization through policy solutions, organizing, and public education. Tasha.
Thank you so much, Professor. Good morning, everyone. It really is a pleasure to be a part of this discussion. And so without further ado, I'm going to jump right in. As the chair mentioned, Measure 110 was a voter-led initiative in the state of Oregon in the United States that made that state the first in the US to pass a decriminalization policy. It passed with close to 2/3 of the voters who voted in favor of this initiative. And it decriminalized or eliminated criminal penalties for possession of small amounts of drugs for personal use. The law also allocated funding for a range of health and recovery and addiction services. Unfortunately, succumbing to a disinformation campaign, Oregon politicians voted to undo key aspects of the reform and reinstituted criminal penalties for drug possession. So I will provide a little bit more context about what happened. But first, I want to just summarize some of the key aspects of what the initiative achieved, and also talk about some of the confounding factors at the time the law was implemented. So some of the achievements, well, one of the primary goals of Measure 110, and I'm just using that term for short, which was the Decriminalization Initiative, was to shrink the role of the criminal justice system as a response to drug use, and instead to treat it as a health issue. The goal was to remove some of the primary barriers to treating drugs and drug use as a health issue. Measure 110, by that standard, achieved its primary goal. Arrests for drug possession declined significantly after the law took effect, after the law took effect in February of 2021, resulting in thousands fewer people who are saddled with criminal records for low-level possession offenses. Measure 110 also increased health and social services for people who use drugs, investing $300 million in the first 2 years of the initiative, and expanded services to parts of the state where those services were not existent before. This resulted in a significant increase in the number of clients accessing services in the state of Oregon. And prior to the measure being implemented, Oregon was near last in access to treatment compared to other states in the US. It also had a high level of people who were incarcerated for drug possession offenses. So based on those two criteria, Oregon, in addressing the hypercriminalization of drug use, Measure 110 addressed that primary concern. Some of the complications that happened at the time the law was being implemented are as follows. There were some external factors completely disconnected to decriminalization that affected the rollout of this program. First, the arrival of and proliferation of fentanyl on the West Coast, which includes Oregon. And so the arrival and proliferation of fentanyl, the synthetic substance, opioid, that proliferated the market coincided with the rollout of the decriminalization law. I just want to say fentanyl arrived in the US about a decade ago, or a little more, and started on the East Coast and made its way through the United States and finally got to the West Coast. So when decriminalization took effect in Oregon, that's when fentanyl started flooding the market. So what happened, as in every other state in the US where fentanyl started flooding the market, you saw a precipitous rise in overdose rates. And Oregon was no stranger to this trend. And overdose rates did in fact increase as fentanyl flooded the market. But to be clear, independent research from separate longitudinal studies found no link between the decrim policy and the rising overdose rates. and the researchers concluded that the overdose rates were driven by fentanyl, similar to every other part of the US grappling with this synthetic opioid. Another confounding factor was in Oregon, in some of the large metropolitan areas, as well as US in general, there's a severe shortage of affordable housing. That's been an ongoing challenge. But in addition, mere months after the rollout of the decriminalization policy, which keep in mind was, during the pandemic times, the state decided to withdraw some of its pandemic-related protections against evictions. And so what we saw at the time was a number of people lost their housing, and we got to see an increase and increased visibility of people who are unhoused. When you have people unhoused and they use substances, they have no other place to use it but in public. And so there was the increased visibility of drug use, not related to decriminalization, but to the fact that people lost their homes. So just want to say that the homelessness crisis in the US and in Oregon really stemmed from a confluence of factors that was unrelated to the law change. Unfortunately, these external factors have been kind of exploited by those who are committed to a criminal approach and those who opposed the initiative from the time that it was on the ballot for during the election. They exploited those facts of increased homelessness and overdose, and essentially blamed it on the decriminalization policy. And facing increased pressure from the public to do something, the legislature decided to reenact criminal penalties. And so now decrim is gone in Oregon, even though key aspects of the reform that expanded health services still remain. So I just want to do some quick concluding points. In the absence of a social safety net, persistent problems such as homelessness, lack of access to treatment and services will be a convenient way to scapegoat innovative policies. It's important to stress that decriminalization is one component of a public health approach. It is not the only solution. There are a whole host of social determinants of health, so housing, access to treatment, employment, education, that's needed as part of the full puzzle. There's no one clear, silver bullet that's going to solve this crisis. But unfortunately, Measure 110 was blamed for problems that resulted from decades of neglect and failures to resolve these larger structural problems. And despite the impatience of Measure 110, we know we have decades of prohibition and criminalization, and we know where we're at with those decades of failed policies. There was this political impatience with decriminalization, and unfortunately it was repealed. But despite that impatience, we know that criminal penalties are not the answer to problematic drug use. And the experience in Oregon also highlights the need for safer supply, places, drug consumption rooms, or overdose prevention centers. And it also spotlights why legal regulation based on health and human rights is essential for a true health-based approach. So, thank you.
Thank you, Krishna. I suppose people now in Oregon carefully collect data on what is happening now with recriminalization. I'm thinking of the Czech Republic many years ago that at first decriminalized, then recriminalized, and then re-decriminalized based on evidence. So let's keep that in mind and collect data carefully. Thank you very much. So next speaker is Nick Boyce, who is the Policy Director at the Canadian Drug Policy Coalition, a non-partisan
Canada is one of the few countries that includes civil society on the actual government delegation. I'm taking my badge off, and I'm not speaking on behalf of the Government of Canada right now. I'm speaking as Nick Boyce, Canadian citizen, person who uses drugs, and as a staff at Canadian Drug Policy Coalition. Also, the week's catching up to me. My brain's not working 100%, so forgive me if I'm a bit all over the place this morning. But just wanted to frame this in terms of what's happening in Canada, and we're talking specifically about decrim, but I think this is part of a much broader swing to conservative moralistic thinking about drug use that we're seeing. And that's where I'd like to start talking about the Canadian context. We have federal drug laws in Canada. Those drug laws have never been based on evidence. They are rooted in racist, classist, and colonial ways of thinking. Those laws have been applied disproportionately to Indigenous, Black, and other racialized people, and it just feeds stigma, it feeds political thinking, where we put resources. At the federal level, we do have the Controlled Drugs and Substances Act that sets out the rules around drug use, and within that you can get what's called a Section 56 exemption, which allows for simple possession in certain situations. So for example, it's what gives us the regulatory legal framework to allow for drug consumption sites. You get this Section 56 exemption. The first consumption site we had in Canada is going back 22 years ago. It's Insight in BC, but it was the only one we had. By the mid-2010s, though, increasing overdose deaths and a significant shift in the drug supply to toxic unregulated drug deaths as a direct result of prohibition. By the 2018, we were starting to see an expansion of consumption sites into other parts of the country, and we were starting to see increasing public sentiment that drug use was better to be treated as a health issue rather than as a criminal issue. Also the result from Portugal, the evidence there was really, I think, feeding that public conversation and the political will to start thinking a bit differently. We also, in 2019, the Canadian Associations of Chiefs of Police had a statement in support of decriminalization. I'll come back to talk on that later. And by February 2023, early 2023, the province of British Columbia applied for one of those exemptions to the Controlled Drugs and Substances Act, and actually got simple drug possession. So for certain amounts of certain drugs in certain situations, I can't get into all the details of it there, but the province had decriminalization for certain drugs in 2023. There was no real significant shift in resources, though. Police budgets actually increased at the time. There's lots of problems with the model that I can't get into for the sake of time today. But despite this, within the first 6 months, we were seeing significant reductions in drug possession charges, and we were starting to see increasing access to harm reduction programs. However, as Teshia mentioned, similar in terms of timing for us, it's post-COVID. A lot of people are now unhoused. We had a serious housing crisis in Canada, and there was a lot of visible poverty and visible drug consumption. Again, nothing to do with decriminalization. This is entirely about housing. So within the first few months, we started seeing significant pushback on decriminalization. Public sentiment started changing, and a lot of that was driven by a lot of political misinformation as well. The province of British Columbia then, they had applied for this exemption, but now because of this pushback, introduced Bill 34, which was restricting public consumption of illegal substances act. This criminalized using in public. So you're allowed to possess the drugs, but you wouldn't be allowed to use them in public, even though there were restrictions in the original model that sort of prohibited that anyway. Some organizations, though, stepped up and challenged that legislation, largely because given how toxic the drug supply was in Canada, if you're not allowed to use in public, you're being forced into alleyways, into private areas where you're going to overdose and die. Using in public was the safest thing you could do. So they were granted an injunction while the courts decided whether this legislation was okay or not. I'll come back to that. At the same time, given the toxicity of the supply, we started experimenting with safer supply initiatives. This is where you're providing prescription drugs as an alternatives to the toxic supply, done in very small scale compared to the number of people that could benefit from it, very highly restrictive models. We also had some folks, the Drug Users Liberation Front. They started a compassion club type model where sort of pre-approved members could come in and have drugs that had been tested. Not one person overdosed receiving these drugs. They even tried to go official route and applied for an exemption to Health Canada, and then they were denied that exemption, but they continued doing their work. Unfortunately, the founders then were arrested and charged, and that's had to shut down. It just boggles my mind. It's just ridiculous. We saw the City of Toronto apply for an exemption as well, but because of all this political pushback in British Columbia, Health Canada rejected their application for the City of Toronto to have decriminalization. We're also now seeing it's now 2024 in my province of Ontario. For the last several years, we've had about 20 drug consumption sites, but last year, rather than the current government's been in place since 2018, rather than scaling up these sites or adapting to allow for smoking and not just injecting to match drug trends, they have now introduced legislation which restricts where these sites can operate, and over half of the drug consumption sites are now being forced to close in Ontario. This is at a time where we have one person dying every 2 to 3 hours in Ontario. 7 to 10 people die every day in my province, and they're closing consumption sites. So next week there is an Ontario court case challenging the closure of those consumption sites. We're pretty confident it will do okay. It's also at a time where we're seeing increasing discussions about involuntary drug treatment in Canada. This is very scary. You're closing consumption sites, you're restricting safer supply, you're introducing legislation that criminalizes people, and we have a for-profit addiction treatment system, and we're talking about involuntary treatment. It's very scary stuff. And we're seeing a massive ramping up of the war on drugs in Canada. Over the last 5 years, at the federal level, our Canadian drug strategy spent about $750 million into prevention, treatment, harm reduction, law enforcement. But back in December this year, with all the Trump tariff stuff, we announced $1.5 billion just on border security. That's more than we spent on an entire drug strategy in 5 years. I'll leave it on one small positive note. So we do have that court case in Ontario next week, which I hope will go well. And when I talked about British Columbia implementing this legislation around criminalizing public drug use, that has now been repealed. They did not want to take it into the courts because I think they knew they were going to lose based on all sorts of human rights problems with that legislation. So where we're at now, I think we need to do a lot of public education to tell people what's really happening, show them the evidence, counter the misinformation, and we're having to go the legal challenges route. I think all of this stuff is opening up doors for legal challenges, which is what actually set precedent for Insight, the first consumption site opened 20-something years ago. So happy to answer questions later.
Canada is certainly one of the countries where we can see the power of legal challenge by NGOs. It's been remarkable. Just one very quick question. What's the current coverage of opioid dependence treatment in Canada?
It varies
Talking about the voluntary.
It varies, but in my province, Ontario, months-long wait times to get into publicly funded treatment. Yeah. You can pay to go for private treatment, whether it's evidence-based and the human rights abuses that go on in private drug treatment, that's a whole other conversation. But also the shift in the supply to fentanyl, people's tolerance is so high. Methadone is not enough these days. We need prescribed fentanyl. So a lot of challenges with the treatment system in Canada.
Thank you. So So our next speaker is Isabel Ferreira Alana, a senior coordinator for drug policy at Dejusticia. So Isabel.
Perfecto. Good morning, everyone. Thank you to my colleagues for organizing this. Thank you. So I'd like to celebrate the fact that a Latin American country has had a decrim model for more than 30 years. Actually, last year we celebrated 30 years of decrim in Colombia, and that's not very widely known. So I want to give you a bit of context of how we got there, but also the ups and downs that we've had over the past several years that relate to many of the issues you've mentioned. Personal drug use and possession was decriminalized in 1994 through a constitutional court decision. The sanctions before that were forced internment and 1 year of prison, but the court declared that this was unconstitutional because it went against personal freedom and the liberal state model of our 1991 Constitution. And this decision also gave a twist to a concept that we already have in our narcotics law, which was the concept of the personal dose. The personal dose in Colombia is introduced in our narcotics bill from 1986, and it's 20 grams of cannabis and 1 gram of cocaine. A lot of drugs are not included in that statute, like newer drugs, of course, so we don't have legal definitions for that. And the twist that this decision gave was the personal dose was now a tool to differentiate personal drug use from the intention to commercialize, which was actually a crime. But after that came decades of tensions around this court decision, and the most significant was a constitutional reform in 2009, which introduced drug prohibition at a constitutional level, and it's still relevant, it's still available today. So, and the wording that it included was within the article of the right to health. So although it was intended to be a recriminalization of people who use drugs, because it was included within the article of the right to health, it gave provisions to allow for harm reduction services because it protected the personal use of drugs once again. And the court then reiterated that sanctions are not to be imposed on simple possession and use. But then we've gone back and forth around a number of decisions beyond the concept of the personal dose. The amount that a person can carry that was set at those limits that I mentioned before is very risky, as the thresholds, and Neve, you've studied this. It carries the great risk of unfair penalties for cases where people go slightly over that maximum amount. So the Supreme Court has reviewed cases of people who have been sentenced for slighter, higher amounts, and this case is concluded with the creation of a new concept by the court, which is the supply dose. So as with everything in life, you don't buy like the portion of rice you're gonna eat today, you buy in bulk for what you're gonna use throughout a certain period of time. So the supply dose is basically that. People who go through the criminal system for higher amounts, then is for the prosecutor to demonstrate that there was the intention to commercialize. It is not solely the quantity that demonstrates the crime, but you have to demonstrate that there was an intention to commercialize, or if not, it was just for your personal dose. Actually, this case that brought this precedent was a soldier for the Colombian military who was going into the field for like a 7-month internment, so he brought a bunch of marijuana. Then the jurisprudence also moved with a third concept, which is the shared dose. This court ruling came in 2023, and what it came about through a case where a woman entered a prison and she brought in drugs, but it was to share with her partner an intimate visit. So what the court said is, when your intent is to share with people with whom you have a personal relationship of mutual trust, then it's not an intent to commercialize. It is for your personal use and also for the people you share trust with. So this concept of shared dose came into our scene very recently. In parallel, although we have this decriminalization model, which we're to a certain extent proud of, we also have administrative sanctions within that model. So those are the real tensions that we're going through now. The National Police Code, which was sanctioned in 2016, introduced administrative sanctions including fines, seizing of the drugs for a number of conducts, but most of them are around the fact of drug use in public spaces. Beside of the factors that my colleagues have explained, the other issues that concern like public opinion are around a context where public space is very scarce. Colombian cities have very little public space. And in that public space, who has a right to enjoy that public space? So the whole concern about children and young people and having in parallel people who use drugs and children is a very prevalent preoccupation, and in some cases a very legitimate preoccupation. And there's no clear solution into how to harmonize these tensions of people who all want to use public space. There is not much public space to use in Colombian cities. And how do you make a balanced policy to regulate those tensions? This case also came to the Constitutional Court in 2019, and the Constitutional Court declared that the sanctions of drug use in public space were unconstitutional because they go against the principle of freedom, and it was actually the first court ruling that cited the international guidelines on human rights and drug policy. Congress reintroduced the sanctions, then we went back again, and it got back to the court. What the court did was reiterated that possession and use in itself cannot be sanctioned, but it gave a twist that is very complicated, which it gave the powers to local authority to regulate at a local level when and how you can use drugs in public spaces. So you can imagine how it goes when you take this back to local mayors who are under great pressure from public opinion and also these concerns about what about the kids to provide local regulations. What's happened is that 48 decrees have been issued so far for regulation of drug use in public spaces, and at least 17 of them are blatantly unconstitutional because they do introduce sanctions for just simple possession, which has been declared unconstitutional on several occasions. But they also ignore just the simple rule of the freedom of movement. If you're a person who uses drugs, you just don't have to restrict yourself to one city. If you're moving from one city to the next, and the rules change from city to city. And also the prohibitions are general. Some of these decrees say it's prohibited 24 hours a day, 7 days of the week. So the court ruling stated that it cannot be a general prohibition. If you say no, you also have to say yes and when. The police code is in no surprise being used to target the populations that we all know are being targeted by the police. But beyond that, it is also imposing most of the sanctions of quantities that are lower than the personal dose. So remember I told you that the maximum is 20 grams of cannabis, and 96% of the fines have been imposed on quantities lower than the minimum dose. So that just shows the ineffectiveness of the measures. And then to close with some questions. So the first is, of course, as I mentioned before, this rights intention, and I think we haven't given much thought into how to answer those concerns, which I think are in some cases valid, in some cases legitimate. And in Latin American cities where space is so scarce, how do we solve this tension about people who want to use the public space? And then in the second place is that if it is only logical that if a regulation is going to say when a certain conduct cannot be made, you have to give the provisions of when it can. But that has not been the case for the 48 regulations that have been issued. And that brings us to the third idea, which is how can we use the concept that the courts have given us, especially the shared dose, which is very interesting, to be able to provide creative solutions to harmonize these tensions. For example, the concept of shared dose, can it be used in regulations about supervised consumption sites? Or can it be used to regulate cannabis social clubs? Because local authorities must say, you can't do it here, and you can't do it at this time of day, but you can do it there with these rules and on these regulations. Lastly, we'll be launching a timeline on all of the jurisprudence that I've just told you about, and we'll be launching it, it's only in Spanish, around the Harm Reduction International Conference, so be sure to check out our website to look at all these court decisions, and thank you so much.
Isabel, just a quick question, since we're discussing here about information and manipulation of information. What is in the media on these issues in Colombia?
Everyone is happy about the fact that local authorities have the power to regulate, and the public opinion thermometer is that people want like a stronger regulation and a stronghold, and take back our parks and take back our spaces. There is not that much support to decrim.
Thank you. Okay, our next speaker is Michael Kessler. He's a global health media consultant. reduction and drug policy. So I'm very pleased to introduce a warning, though. Michael is a wonderful professional, a wonderful person. He has a slight Australian accent. Michael.
Thank you, Michelle. I knew you were going to say that. I'm delighted to be here, and I'd like to thank the organisers and especially Neve for having a communications person here, because we don't get to sit at this table very often. I'm sandwiched in here between policy folk, so I've also been given a brief to give a communications perspective. But I would say that, you know, if we talk about silos, which I'm going to touch on a bit later, I think this is a good thing that actually communications people should be on more of these kind of panels going forward, especially in the next 3 or 4 years, which is going to be a very challenging and complicated time. So my brief here today is to go a bit broader than just decrim. I'm going to talk a bit about where global health might be moving and how to sort of maybe understand why there's been pushback on decrim, but a whole lot of stuff, HIV as well. TB, infectious diseases generally, as we've seen in the last 2 or 3, the last 4 or 5 weeks actually. And then I'm going to come up hopefully with a few solutions and a few back to basics. So I am talking to the drug folk in this room, but I'm also talking to sort of broader global health, because drug and social justice that we'll hear about is also part of the bigger stuff around global health as well. I would say, just to reiterate a little bit what Michelle said, I would say, and I'm not saying anything that people don't know here, but I think probably post-COVID, we're in a period of chaos, which is pretty common for pandemics historically. They often end with good periods of innovation and economic growth. That's to be seen in this case, but we are in that period of chaos. I think if you go back to COVID, just now 5 years, I think yesterday or the day before, what started off with massive amounts of empathy, pot banging and empathy with nurses, etc., the longer it went on, dissolved into a whole lot of blaming, and the vaccines came in, a lot of individualism, medical distrust, undermining of science, right-wing agitators in the media with platforms and podcasts wedging that sort of unhappiness with the general public. And what we've had since then is, I think, an exacerbation of that. It's sort of kind of laid the ground for what's actually happening at the moment, especially with the US administration in terms of the undermining of science, the pushing back of drug policy, the pushing back around HIV. And, you know, it might not even seem a major thing, but if you go back to the election campaign, you know, even some of the words that came out about viruses and disease and spreading, and the Haitians were going to bring HIV here, and we had a virus of misinformation. A lot of the politics has been medicalised almost in our communications as well. And I think that's an important point to realise as well. But at the same time, with this undermining of science and public health, people's distrust in health, I think, is higher than it's ever been. It's also been accompanied, and we shouldn't forget this, way before COVID, with the shrinking of legacy media, traditional media, if you like. Okay, this has been going on for years. You know, where there were maybe 5 health journalists in a room, there's now, you know, maybe 1. Okay, media rooms have shrunk. Traditional media is closing. Journalists can't keep up. I've just been to Rwanda and Boga to prepare for the harm reduction conference, and I spent a lot of time with journalists while I was there. And I've asked all of them, you know, how do you feel about what's happening at the moment with the convergence of Silicon Valley with the Republican Party, because that's what it is. It's a convergence. It's a political alliance. And they are all trying to catch their breath. They can't keep up. They know they can't keep up. They know they're not even winning. And the main thing that most of those journalists said to me in Bogota and Rwanda was, the only thing we can do is just keep on being accurate. And that's where they see things. But they understand that this is kind of a losing battle at the moment. I want to touch a bit on that political alliance that the Republican Party have too with Silicon Valley as well. I think there's no doubt that this pushback on decrim and public health, generally speaking, is being thought out as an information war. This is an information war. It's really, really obvious it's an information war. This convergence, I say, of Silicon Valley with the Republican Party is incredibly complicated. I don't know what the solution is here. I think, you know, is it a Soros? Is it a Branson stepping in with a new social media tool? I don't know. I'm just throwing that idea out there. How do we tell stories that we've always wanted to tell around drugs, around HIV? I think the solutions here going forward are, I think, people here in the drug world. I think we all need to be talking on the same page. All the communications people in the drug world need to be talking on the same page. And I think as we go into a sort of a period of maybe having conversations around a global health reset, which will happen at some stage or other, I think we also need to have a bit of a rethink about communications. You know, I've been doing this now for nearly 3 decades, and, you know, NGOs, generally speaking, are not brilliant at investing in communications. Maybe comms, but media relations, which is what I do for a living, eating and having coffee with journalists, not many people do it. And it's no coincidence that Amnesty, Greenpeace, those guys are incredibly successful because they invest in communications. And when there are cutbacks, they don't cut back on their communications people, they cut it from elsewhere. And I think maybe there are lessons to be learned there that going forward we need to be smarter. You know, the Portuguese comms people need to be talking to the UK comms people, to the French comms people, and we're all on the same message so we're not exposed to political pressure from the outside. I also think, in a very, very basic way as well, some of the really simple things still work. You know, I don't know how many people in this room or anybody who works for an NGO has ever sat down with a journalist and had a coffee or had lunch and sort of chewed the fat with them and talked about where things are going, but I don't think we do it enough. I do it for a living, but I know most people don't actually get around to doing that. A journalist in an average day gets hundreds of media releases, and the only ones they're going to read are from the people and the organisations that they trust. The people who actually go to time and actually speak to them. There's some really good examples in the drug world. I think, you know, Transform are really good at comms. They're really, really excellent at it. I think the DPA Alliance is really good, and Vital Strategy is really good on the overdose stuff. But in general, I don't think we get out enough. And I think more than ever, because we're in a very, very compressed state at the moment, we need to go back to what is the most basic element, and that is we've got to tell a human story. You can complain about right-wing media coverage of your story, fine. But you can't really complain unless you've actually gone out and briefed the journalist, I don't believe. I think it's our obligation to spend time with journalists, teach them the story, show them the story, and take them to the story. We have to take journalists now to the field. We have to take them on field trips. Journalists are not allowed out of the newsroom anymore. Even in their own city, they're not allowed to go to conferences because they're all virtual. But their editors will send people on a field trip to a slum in India to go and see a drug policy project, to go and see the safe injection in Bogota, which we're going to go and do at the harm reduction conference, to go and see the drug checking service. They'll send journalists to go and do that. And I think going forward we need to sort of think about that really basic quality. NGOs might not have funding for comms people, but I don't think that matters. I think there's enough people in NGO who are really, really good and know the field really, really well, who are capable of going out and speaking to a journalist once a week and having coffee and chewing the fat with them and telling them about the big picture. If they get the story wrong then, yeah, give them a hard time. But I think it's incumbent on all of us to sort of remember that, along with the possibility of a Branson or a Soros stepping in terms of having a wider political information alliance, I think we really, really need to be cognizant of the fact that we need to be telling what is essentially a very, very human story. And the drug world has some of the most inspiring, heavy, but exhilarating stories to be able to be told. And I think it's incumbent on us to be able to tell those stories, I think, more and more so over the next 3 or 4 years in what's going to be a very, very challenging environment. Thank you.
Thank you, Michael. Lots of thoughts and advice also to all of us. I was interested in what you said about the post-COVID chaos. Because if you think populism has not traditionally been anti-science, it's really recent populism that is anti-science.
Yeah.
And I do believe that this is part of the COVID or post-COVID chaos, as you pointed out. So we'll be able to science, and will the media help us in this?
That's a good question.
And we have no time to discuss this. why was COVID associated with the nascent anti-science movement? Because populism is against the elites, and somehow people perceive that the elites were taking the power during the COVID crisis. Okay, thank you. Next speaker is Daniel Deloy, who is the Deputy Director of the Law and Policy Program at Amnesty International. Thank you very much for being with us today. Daniel, the floor is yours.
Thank you very much, Michelle, and thanks to the organizers for the invitation to be here. I've been asked to talk a little bit about how UN human rights mechanisms can be an avenue to challenge the prohibition and criminalization of drugs, and how these mechanisms can be used to trigger reforms at the domestic level, and hopefully also to be a source of trustworthy information to counter misinformation. But let me briefly start by explaining what these mechanisms are and why they can be relevant for the drug policy reform movement. UN treaty bodies are independent expert mechanisms overseeing the implementation of each of the 10 key human rights treaties that you can see there, although in a very small letter, sorry for that. But when a state ratifies a treaty, it assumes the legal obligations to implement its provisions and abide by them. States have to report periodically to these committees on their progress on the implementation of the treaty, and each committee then reviews these reports and monitors the compliance. So experts in these mechanisms, as I said, are independent, even though if they are nominated by the states, they do not represent the state, which provides a very important platform for advocacy for us as civil society organizations. And treaty bodies have various functions that can be relevant for advancing drug policy reform. The first process is country reviews, and this has been increasingly successful in addressing human rights violations stemming from punitive drug policies. During country reviews, states are requested to submit a report to the committee on how they are complying with their respective obligations under a treaty. The committee then asks the state specific questions, and then they organize an interactive dialogue between the committee and the state to assess how the implementation is going and the human rights situation in the country. As part of this process, civil society can submit written contributions that enable the experts to better assess the situation in the country. Civil society organizations can also attend the interactive dialogue and use certain opportunities to brief the members of the committee, although civil society organizations do not take part in the formal dialogue, which is only between the committee and the state. But these reviews have created incredible opportunities to expose patterns of abuse, to highlight the need for certain legal or structural reforms, and to shape the committee's recommendations to ensure stronger human rights protections. At the end of the review, the committee issues a set of recommendations that are known as concluding observations. And while these recommendations are not legally binding, they are key advocacy tools that can then be used at the local level to further engage with the government and push for reforms. Over the last decade, treaty bodies have been paying more and more attention to drug policy and the multiple human rights violations associated with it. However, it's important to say that the degree of engagement and the extent of the recommendations that we are seeing coming out from each committee varies from treaty body to treaty body, and a lot has to do with civil society's involvement. The Committee on Economic, Social and Cultural Rights has been perhaps the most vocal against the criminalization of drugs, and has started to systematically call for the decriminalization of drugs and for other health-related reforms in the country. See, for example, these recent recommendations to Lithuania and Cambodia, where the committee specifically urged the country to decriminalize drug possession for personal use and to increase access to health and harm reduction services. Other treaty bodies have had similar recommendations. I'm not going to go into detail on this to save some time, but this one, for example, of the Committee on the Elimination of Discrimination Against Women. But achieving concrete and strong recommendations is only part of the process, though, because their implementation will require the persistence and long-term commitment from various stakeholders. The line is not always straight from the recommendations from a treaty body to action at the domestic level. But international recommendations have been, in many instances, important building blocks in wider advocacy strategies. In some countries, for example, governments have established formal processes for implementing international recommendations. In Canada, for example, civil society pushed for the creation of the Forum of Ministers of Human Rights, where the authorities meet around every 2 years to discuss the country's international human rights obligations. In other countries, the courts, for example, have mandated the state to implement certain decisions or certain recommendations by international mechanisms. And there are several initiatives in different countries running now through Congress to make the recommendations legally binding directly. So imposing a direct obligation on the state to implement what international mechanisms are saying. The second process that I wanted to briefly mention is what is called as general comments. Treaty bodies have a key role in developing international human rights law, and they provide authoritative interpretation of specific provisions of the treaty and their application to cross-cutting issues. So all treaty bodies have developed specific general comments on their respective area, which are important sources of law where the committee can set out specific obligations or explain to states how they should implement specific rights in the treaties. So general comments can be important tools to further develop our understanding of how punitive drug policies can lead to systematic human rights violations, and to ensure that treaty bodies properly address the concerns around drug policy during their interactions with states. So many times the treaty body, the committee, follows what they set out in the general comment during the country reviews, and they go one by one of the issues in their interaction with states. Some general comments to date have already touched on specific issues related to drug policy. For example, a general comment from the Committee on the Rights of the Child on the implementation of the rights of the child during adolescence that sets specifically some standards around health and harm reduction for children. It also sets the prohibition of criminalization of children for their use and possession of drugs. But more importantly, I wanted to highlight the relevance of a process announced a few years ago by the Committee on Economic, Social, and Cultural Rights to develop a general comment specifically on the impact of drugs on ESCR. Many organizations have already been engaging in this process, as this is a key opportunity for the committee to expand notions of human rights in drug policy and, again, provide authoritative guidance on states on how to fulfill their obligations under the covenant. It's also important to say that despite the solid groundwork developed by some other committees to assess specific drug policy concerns, there is also a need for some treaty bodies to follow the work of the Committee on Economic, Social, and Cultural Rights and address the root causes that are leading to these human rights violations in a more comprehensive way, which basically means to challenge and condemn the criminalization and prohibition of drugs. Very quickly, finally, the last process I wanted to touch upon is individual complaints. Treaty bodies can also consider individual allegations of human rights violations in certain conditions that I won't go into detail for lack of time. But just to say that civil society can also intervene in these processes before the committee. They can submit third-party interventions, which also helps the committee to assess and better solve, I guess, this case and advance international human rights law. So over the last year, Amnesty has partnered with many civil society organizations litigating on the ground, using domestic courts and international human rights mechanisms as triggers for reform. We are still awaiting the results, the orders in these cases, but we have definitely seen the potential of harnessing international human rights standards when litigating at the domestic and international level, and we're constantly looking for more opportunities on how to intervene. Just very quickly, as a very final thought, I think it's also important for us to consider how we can use all these mechanisms, not just to advance drug policy reforms at the domestic level, but how to use it to challenge and trigger changes at the international level, and particularly here in Vienna. I think we all know about the dissociation from Geneva to Vienna, and I think we need to be thinking how to use these mechanisms more to ensure that dialogue with Vienna, to make sure that those decisions that are happening in Geneva are brought to Vienna and are actually having an impact in the discussions and decisions that are happening here in Vienna. But I'll stop there. Thank you very much.
Thank you for helping us understand all of these instruments and how useful they can be. Let's also hope that the international order will prevail. So our last speaker, and thank you to all, we're right on time, is Niamh Eastwood, the Executive Director of Release. Release, known to everyone as one of the organizations that's really is at the forefront of the fight for decrim. Niamh.
Thank you, Michelle. And thank you everybody for coming this morning. I wanted to talk about the international guidance that are being developed by UNAIDS, and Michelle, I agree that we hope that the international regime continues. But the guidance, the work on this started last year, and this is UNAIDS developing technical guidance for in-country work to develop decrim models at a local level that are effective at reducing barriers to HIV treatment services. And it's been done in coalition with Release, Input, and the Centre on Human Rights and Drug Policy. And we've been doing it through community consultations, so speaking to people who use drugs in countries where decriminalisation has already been enacted, and what their actual experiences are, and what the challenges are, what the positive effects can be, recognising that no model is actually operating in a way that advances the rights of people who use drugs. We've also had input from 50 academics and country stakeholders. And I think I wanted to share some of the divergence that has occurred through this consultation in light of the experiences, particularly in Oregon and in Canada, and this idea of what decriminalisation can achieve as a policy framework. And many of our experts have come back and said, we need to also, alongside decriminalisation, in order for it to be effective, to have housing strategies that reduce the risk of public drug use, that reduce the risk of media and political and public backlash, in order for decrim to be successful. And that's got us thinking about, well, what is it that we are advocating for, and how do we manage expectations of policymakers and the public and the media? And so I think some of the work that we do as NGOs, and speaking to Michael's point about engaging with media, is really, when we start to do advocacy, is to recognise and manage the expectations that society more broadly may have on these policies. And at the core of this work, we've really kind of thought, because we're hopeful that the guidance will be quite progressive in terms of what we're calling for around sanctions, around reducing contact with law enforcement, because even if we retain administrative sanctions, that fear of policing can limit people's access to services. And so I think at the core of it, we need to be really clear on our advocacy and say, look, decriminalisation can reduce the burden on state resources. Less cops, less prosecutions, less court time. And it can increase access to services. I mean, both Nick and Tesha have both highlighted how that has happened in Oregon. And we know that criminalisation acts as a barrier to services. In the UK, for example, 16% of students have stated that they did not seek help in an emergency situation with drugs because of fear of police. And that's 1 in 5 kids. Parents don't want their kids to use drugs, but they sure as hell, if they do use drugs, want them to be able to access services. So these are the things that we have to start framing, I think, of what decrim can do. And 50% of people in the UK who are dying of overdose deaths, of opiate overdose deaths, have not been in contact with treatment services for the last 5 years. Again, recognising the role that criminalisation plays in it. And so within the guidance, what we're talking about is really managing what this policy and legal framework can achieve. And what it cannot do is address a global housing crisis. That is a crisis of inequality. Decriminalisation will not fix that. Oregon post-COVID saw a 37% increase in homelessness. During the same period, the UK experienced a 45% increase, France experienced a 133% increase, and Brazil a 140% increase. None of those countries have decriminalised. Brazil is doing work around it, but none of them have. It is not a decriminalisation issue. And just quickly on challenging misreporting in this space, the role of the New York Times and Washington Post in particular around Oregon, and highlighting that Portugal had been a failure, that Portuguese politicians were regretting decriminalisation that had been enacted in 2001, was an absolute failure to properly report what was happening in Portugal at that time in 2022, when Portuguese legislators were reinforcing the decriminalisation model and expanding it. They were removing thresholds and allowing and creating a system where people caught above the threshold could still benefit from decriminalisation. They were adding synthetic opiates to the decriminalization model in Portugal. This was the opposite of what was being reported in the press in North America. And so, again, coming back to Michael's point about a global echo, about how us as NGOs, in a very challenging time, support each other to come forward and really challenge misreporting, misinformation and disinformation. So thinking about how we do that, whilst also managing what these policy reforms can actually achieve, which is a huge amount in their own right, but they will not solve all of the problems. Thank you.
Portugal was also opening drug consumption,
Yes.
consumption spaces at
Yeah.
that time.
Yeah.
Yeah, we are in times where we're coming to ask whether truth is a political question.
Yeah.
So we have time for 2, 3 short comments, questions, and thank you to all of the speakers. Wonderful session, and thank you for staying with time. So 1, 2, 3.
Thank you. My name is Erik Knudsen from the Association for Humane Drug Policy in Norway. Thank you so much for your great presentations. I hope this question is relevant, but I wonder what is the Decrim model in Oregon? Because they don't seize the drugs, do they just leave? Is there no policing? How could they blame the fentanyl? And for Daniel, we have a national institution for human rights in Norway that looked into it and said we cannot say that criminalizing people for using drugs is a human rights problem. What is your response to that? And I was trying to follow you. I'm Norwegian. You talk so fast. So I didn't get all the sentiment.
Thank you.
Mexican.
Yeah, I guess my question is a rather simple one. I'm also from Norway. I'm from the Norwegian Association for Safer Drug Policies. I feel very often that fear is very efficient as a method of communication. You can always say there are drugs everywhere, there are criminal gangs everywhere, we need to pipe down. And fear leads people to, authoritarian measures and some big strong state and police that's going to save them. So if we want to meet this sort of fear-based, simple communication, facts often seem so inefficient in reaching out. So I guess my question is, how can you sort of face the scare tactics of the war on drugs in a fact-based way where also people listen? It's not enough to be right if no one hears you.
Yeah, thank you. Michael, that's also for you. Yes?
Just a question for Tesha. Oregon, July 2021, brought in its decriminalisation. By December of 2023, drug deaths have gone up to 1,250, and about 450% increase, 4.5 times greater. And there seems to be this phenomenon with decriminalisation, as with shoplifting in California, where you make what had been a felony equal to a parking fine. Seems to be this phenomenon of very much increased harm, and Oregon most definitely saw that. You said that academics didn't think that there was any relationship between decriminalisation and the massive increase in deaths. Can you give us a bit more on why they didn't think of that? I understand the harmlessness, but again, it's way out of whack with the whole of the US. Fentanyl deaths didn't increase across the whole US by 450%.
Okay. Just last question. Yes, sorry, please go ahead. No.
My name is Joe Thompson, Dr. Thompson. I'm from the Caribbean. And I'm wondering if in Oregon, in Canada, as Michael said, there's been a failure in terms of the journey. There's a message coming out there. One, Michael, we have to sit down with you and buy you lunch. But that there has to be, as you're saying, this pushback to get that message out, because the failure in Oregon, and as you say in Canada, has been a lack of a different type of response. We recently had cannabis SPG in St. Vincent sure the journalists were there to be able to carry that particular message. So I'm getting that coming out of this side event. You've got to engage the journalists.
Thank you. Sorry, let's have a quick round of answers. Fesia, I think, and Michael, maybe Nick, you want to add something? Daniel, or yeah? Well, Fesia.
So when you asked about decriminalization and how the Oregon law was implemented, it was decriminalize thresholds of certain substances, and people caught in possession what you should have fined. So it was a civil citation. At that point, cops were authorized to seize it because it is prohibited if decriminalization is an legalization. So that essentially was the way the decriminalization law was written. With recrim, it's now essentially those same thresholds are now a misdemeanor, so subject to jail time of up to 6 months.
So how can they blame the fentanyl?
Yeah, no, absolutely. So I'll just quickly say, I mean, when fentanyl entered the market throughout the U.S., we saw rapidly rising overdose rates. That's what happened in Oregon. All the states surrounding Oregon that criminalized drug possession had similar or even higher rates of overdose compared to Oregon at the time decriminalization. So if you look at the state of Idaho, where it's a felony to possess drugs, and you look at surrounding states, Washington State, California. I know you mentioned California, there was a decriminalization of drug possession. That's actually not true. So similar rates. So all I'm saying is, like, if you look at the surrounding states where as fentanyl flooded the markets, we saw similar or even increased rates of overdose compared to Oregon. It's just, yeah. So anyway, I mean, the only difference between Oregon and these other states is Oregon decriminalized, where some of these other states retain criminal penalties. So if you take out, whether decriminalized or not, fentanyl was flooding the markets in all of these states, and we had similar rates.
Nick?
Just quickly on the death point as well, to back Tesha's point. In Europe, if you look at the countries that have decriminalized, the drug-related deaths, and this is mapped across all of the countries in Europe, are much lower than those countries that criminalize. So for example, if you take Portugal, the death rate in Portugal is about 10 per million of the population. In the UK, it's 76 per million in the population. We see similar stats in Norway and all of the Scandinavian countries that take a criminal justice approach. So we have some indication, I wouldn't call it full evidence because it hasn't been analysed in that way, but that decriminalisation is definitely creating spaces whereby we have lower rates. So we have that in Portugal, in Spain, in Germany, all of the countries across Europe that take a non-criminal justice response to death.
Hold on, we're not entering into a further debate here.
Yeah.
Just a quick word from Nick and Michael on the comments we had. Yep.
First, if anyone wants to follow us along, I got some cards here if you want to follow up afterwards. Decriminalization, it's so important in terms of access to healthcare, in terms of righting historical wrongs, in terms of racial and equity. What it does not do, and this is from a Canadian perspective, it does not regulate the supply of drugs. And that is the issue. And we need to move beyond decriminalization. We need to work on decrim, but we need to move beyond and into legal regulatory models.
Thank you. Michael?
Fear. How do you fight fear? This comes back to the human story. I would say from the beginning that I don't think we're in the same place that we were 10 or 15 years ago. People talk, even in the UK, people talk about marijuana now and ecstasy in a very, very different way than we did 10 or 15 years ago. We've had decrim of cannabis in many places. We are in a very, very different place. We also have a very different generation of parents, my age, who have, who've taken drugs, as opposed to my parents, who probably didn't. So there's a much more liberal set of generation there too. In terms of fear, I really do think it's a human story. I'll give you an example. The medically supervised injection room in Melbourne, where we took journalists 2 years ago at the harm reduction conference, had never had journalists inside that room. And we bought for the first time with Helen Clark, we leveraged Helen to be able to get permission to get the media in there. 5 years they've been open, they never had a journalist in there. We took some of the most experienced health journalists I can recall in Australia to that centre, and they were blown away because they saw the biggest HIV, the biggest hepatitis C testing clinic in Victoria there, HIV clinic, a housing officer, a dentist, a COVID room, 15 nurses, doctors. They were surprised. On Point in New York City, for example, in terms of fear, On Point have an extraordinary floor at the top of their safe injection room where we went with Michelle and Louise Arbour last year from the Commission, where they actually provide free massages to all the clients who use the centre. But more than that, anybody who lives in East Harlem can actually get a free massage too. Now that's one way of combating fear, because they actually get to see the centre and they realise there are doctors, nurses, social workers, etc. Again, I think it comes down to, I think most people are fearful of things that they actually don't know about. But once they see human beings being treated nicely and see doctors and nurses, there's an empathy level there that raises. So that would be one way of combating fear.
With this, let's close this session.